this way here. The head on your back and the head to myself. So the legs in this direction, to put it that way. Okay. So come closer to me. You can do it. Okay, come closer. So Dr. Anita is now demonstrating the maneuver. So very simple. And based on the Bandari simulations, we have now modified also the treatment. Maybe then you see a nice tacmus, which is the mirror image of posterior canal. In posterior canal, you have a nice tacmus beating like this. And in anterior canal, you see nice tacmus which beats like this, which is also an excitation of the anterior canal. And then you can move on with the treatment. And this is a modified Jacobino maneuver. Patient sits up with the head upright, so it's easier. And then after 30 seconds, bend the head 30 degrees forward. And then after another 30 seconds, the patient is upright. So there are two things which you have to consider. Why is anterior canal so rare? Well, the anterior canal you can also call superior canal. And therefore the risk is very low that the crystals fall into the canal. And I think we all do these movements overnight when you get up, and so they treat yourself very easily. And what Anita and her husband found out is the modified Jacobino maneuver. Because the regular Jacobino maneuver is theoretically not working. There's no need to do that. So once again, patient stayed flat, head overextended 30 seconds for 30 degrees, and sit upright another 30 seconds, then bend forward and sit up again. Very simple and straightforward. If you're very lucky, you will see 1 or 2 patients with anterior canal in your lifetime. Most often, this is a central positioning nystagmus. If the nystagmus beats like this or this, then it will be a central positional nystagmus. 3 aspects, last comment, on central positional nystagmus. First, you do different maneuvers and get a similar nystagmus. The second criterion is, most of these patients, since it is cerebellar, do have additional cerebellar oculomotor disorders, like saccadic smoke pursuit, gaze-evoked nystagmus, or even easier, a downbeat nystagmus. And the third criterion is, and we published the review 2 years ago on this topic, that patients do not respond to the treatment maneuvers, and the nystagmus does not correspond to a canal. So in your clinical practice, most often easy to diagnose. Treatment of choice is foraminopyridine, fampiridine.
Câu hỏi trực tiếp cho giáo sư Michael Stubb. Please tell me about treating secondary BPPV after acute neuritis.
Okay, 2 things you have to consider. First, if a patient deteriorates after vestibular neuritis, it can be secondary functional dizziness, or it can be post-infectious BPPV. The question is, why do you get BPPV in vestibular neuritis? Well, in vestibular neuritis, only the superior part in most patients of the vestibular nerve is affected. That means a dysfunction of the horizontal and anterior canal, and the function of the posterior canal is preserved. Otherwise, you wouldn't get BPP. Secondly, we demonstrated that there's also herpes simplex virus in the labyrinth. So in many patients, it's not only a neuritis, but also a labyrinthitis. And any inner ear disease is associated with a higher risk of a dislodgement of the otoconia. Therefore, you get that. So think of it and treat it in the regular way. There's nothing otherwise particular.
Vâng, còn câu hỏi cuối cùng cũng hơi khó nhỉ. Cách xác định bệnh nhân bị rung giật nhãn cầu. Thì nếu mà khó quá thì chúng ta có cái kính M glass nữa.
Sorry, I didn't like
Cách xác định bệnh nhân bị rung giật nhãn cầu.
It's easy. Look at the patient's eyes. That's all.